So this will not be a formal lecture. This will be a more of a discussion class. So we'll be going through the gross specimens. We have divided practicals into 5 parts. Okay, means one will be the gross section, which we'll be discussing today, either part or fully we'll be discussing today. Then we'll have the microscopic slides, and then we'll have the hematology slides, and then we'll have the instruments that are used in pathology laboratory. These are the 4 things, and the other one is the practical which you have to do, like hemoglobin estimation or blood grouping, those practicals. That means they are in 5 parts. Now, these gross specimens, there are a total of 23 gross specimens for the first year, and there are 34 microscopic slides, and there are 9 hematology slides, and there are 10 instruments. So there are a lot of things which you should remember, including all these things. And your exam was interrupted in between. So either you have appeared the pathology class or not, you should be ready for the practical exams, because we don't know what will happen. Either you have to appear it again, or it will be continued. So you have to be ready with the exams, so that we'll revise the all the practicals, and moreover all the practicals will be from whatever we go through in these revision classes. And you have already been taught all these things in the practical classes, and you have already gone through almost all the things. And if you have not, please go through these things very seriously. We'll start. Seeing a photo is not exactly like seeing the whole specimen. Okay, you just try to correlate. This is the gross, first gross. Okay, here you also try to discuss. Okay, so what do you see here? What do you think it is?
Appendix.
Okay, very good. Very good. Why appendix?
Rounded structure.
Okay, more than rounded structure, I will say a tubular structure. Okay, a tubular structure. And here you can see the dilated lumen of the appendix. Generally, the lumen of the appendix is very small. And here you have, here will be the points. This is the specimen of the appendix, where the serosa has, externally the serosa is gray colored with congested blood vessels. The wall is thickened and lumen is dilated, which you can see. The lumen is dilated and filled with necrotic debris and fecalith. Fecalith means?
Fecal matter.
Okay, fecal matter, or you can call it fecal matter. Okay. So there are some questions which have already been discussed in a class, like what are the types of inflammation? Acute inflammation, chronic inflammation, and in learning of the difference between exudate and transudate with examples. This you should know. So this is the scope, beyond the scope of this discussion. Okay, so we won't discuss this. So we'll try to discuss the gross points and the gross picture. Okay, here you can see a specimen of an appendix. it has a externally gray colored here due to the formalin for a long time. It is here in the formalin for a long time, so it is slightly discolored. But every specimen is discolored, but it has preserved features of acute appendicitis. Okay, here you can see that the tubular appendix is dilated. It has congested blood vessels, which is seen here. The externally it is gray, okay, and there might be some exudates which are in the overlying the serosa, and there is a dilated lumen which contains fecal lith. So this is about the appendix. So roll number 5, can you please revise whatever we have learned about acute appendicitis? Okay, roll number 7.
Yes, sir.
Okay, this is Suman Adhikari, right?
No, sir. I'm roll number 7.
7. Okay, Suman Adhikari. Okay.
I'm Kushal Singh Vasant.
Okay, wait, let me see. Okay, Kushal Singh. Can you please revise if you know?
Appendix is a tubular structure.
Okay.
And it is present with fecal lith.
Okay.
And there is some area of necrosis.
Okay.
And acute inflammation is present.
Acute inflammation. So this is a gross specimen. So acute inflammation, to say acute inflammation, you can either see grossly the signs of inflammation. Yes.
Yes, sir.
So what are the signs of inflammation?
Rubor, calor, functional lisa, dolor, and tumor.
Okay. I hope you know all the what does these all things mean.
Yes, sir.
Okay. Then you should, in a gross specimen, you should see those features or the signs of inflammation. Then only you can say this is a acute inflammation.
Yes, sir.
Okay. So here you see this is a specimen of appendix where externally the serosa is gray white. Okay. With congested blood vessels, the wall is thickened and the lumen is dilated and filled with necrotic debris and fecal lith. So this is a acute inflammation. For example, acute appendicitis. Okay. So a question will be, for example, like this: a 9-year-old boy was brought to the emergency with complaints of pain in the right lower quadrant of the abdomen. So you have to know that here in the right quadrant of the abdomen, right lower quadrant of the abdomen, there will be presence of appendix, and the patient has a 9-year-old boy has pain in that area with fever and vomiting, and he has a leukocytosis with total count of 17,000. Then everything is matching with acute appendicitis, a clinical scenario of acute appendicitis. Then a gross specimen of an appendix is kept. Then the first question is, what is your probable diagnosis? Then you have to write probable diagnosis is acute inflammation and in bracket acute appendicitis, or you can directly write acute appendicitis. And what is the predominant inflammatory cell in this disease? So it will be
neutrophils.
Okay, very good. It will be neutrophils. If it was a chronic inflammation, then it would be lymphocytes, plasma cells. Okay. So let's
mononuclear cells.
Okay, mononuclear inflammatory cells. Very good. Let's go to the second gross specimen. This is the second gross specimen. Can someone guess what this could be? Or if you know?
Tuberculosis lymph node.
Okay, very good. Somebody of you have told this is a tuberculous lymph node. So can you please elaborate what are the features which favors tubercular lymph node?
Matted appearance.
Very good. Very good. Other?
Caseous necrosis.
Very good. Caseous necrosis. So those two are the very important and I should say most important features of a tubercular lymph node. If you see a matted appearance along with caseous necrosis, then you can say it is a tubercular lymph node. Okay. Here you can see this is actually not a single lymph node but a conglomerate of many lymph nodes, or it is called a matted appearance. Okay, with multiple nearby or approximate multiple nearby lymph nodes are getting approximated and they are sticking together. So this is called matting. And here you can see these are the necrotic areas. Multiple areas of necrosis are there. Okay, even this. Multiple areas of necrosis which are getting confluent. So let's see the points. This is the specimen of multiple lymph nodes. Okay, the multiple lymph nodes are adhered to each other, which is also known as matted, and there is yellowish areas of caseous necrosis, which has a granular cheesy appearance. That's why known as caseous necrosis, because of its cheesy appearance, and it is seen in the center of the lymph nodes. So if you see these features, then it is now a tubercular lymph node. In this, you have to know the questions. What is the difference between a granuloma and granulation tissue? What type of inflammation is seen in a case of tuberculosis? And what are the difference between acute and chronic inflammation? So these are the questions. After correctly identifying this gross specimen, then these questions might come to you. So you have to know these questions, which is already in your logbook. So you have to go through these. By far, till now we have learned about acute appendicitis, and this is the tubercular lymph node. So a question will come like this. A young boy had cervical lymphadenopathy. So directly here is lymphadenopathy. It was surgically removed and the cut section of the specimen is shown. That means you have to identify the matted appearance and the caseous necrosis. So then what is the diagnosis? Diagnosis is tuberculosis lymph node or tubercular lymph node, which is a chronic inflammation. Okay, tuberculosis lymph node, and then write two features that support a diagnosis. Then with the features we have already discussed before. Okay, shall we go ahead?
Yes, sir.
Okay, that means everything is clear till now.
Yes, sir.
Okay, this is the third gross. Can you people give some idea what? Okay,
Lipoma.
okay, very good. Why do you call this a lipoma?
Whitish mass.
White mass, yellow white. Fatty.
Okay, yellowish white mass. Okay, very good.
Encapsulated.
Okay, very good. Encapsulated.
Greasy surface.
Very good. Very good. So these three are the most important things. All right. So we'll go through the specimen. It is a well circumscribed lobulated tumor mass. So from here we know that specimen shows a well circumscribed lobulated tumor mass, and the outer surface is smooth and encapsulated. So from these points, we know that this is a benign tumor. Okay, and the cut surface is solid with yellowish fatty areas. So this shows that this is a benign tumor of the fat origin, which is lipoma. So this is a lipoma gross. These are the identification points which we have gone through. I hope you all have understood this lipoma, gross of lipoma. So questions, what are the common site for this tumor, and name 2 other benign tumors. This you can do, I know. Now, question might come like this. A 30 years male presented with a large lump over the shoulder for a duration of 5 years. So this is not a malignant tumor. Why? Because there is a duration of long time and the lump is not increasing in size. This is also a feature of a benign tumor. If it was a malignant tumor, then the lump would be there for a shorter time, shorter duration, and it would be massively increasing in size. So what is the identification of this specimen? Lipoma. And name the malignant counterpart of the lesion, that is liposarcoma. I hope you are clear with this.
Yes, sir.
Okay. Shall we go to the next part?
Yes, sir.
So, can someone please discuss this? Fourth
Squamous
gross
cell carcinoma. Squamous cell carcinoma.
of the which area?
Of oral
Oral.
cavity.
Oral cavity. So, what is the gross which we are seeing right now?
There is squamous cell carcinoma.
Okay. So here you can see the mandible, right? The ramus and all the mandible, part of the mandible, and maxilla. Okay, maxillary part of the maxillary bone, and then there is some soft tissues of the cheek. Okay, muscles, and there is irregular mass. Okay, you see the identification points. This is a specimen of part of the mandible, maxilla, soft tissue of the cheek, and the overlying skin. And the buccal mucosa shows an ulcero-proliferative growth. So there is a ulcero-proliferative growth. This is the specific word which you should write in the exam. This is the best word to describe this tumor. And for squamous cell carcinoma in other areas also, they will mostly be ulcero-proliferative. So this ulcero-proliferative word you should be very particular in case of squamous cell carcinoma. So when this cross comes, you have to write ulcero-proliferative growth, which is a very good word to describe. And the cut section of the growth shows gray white areas, and the tumor is seen extending or invading into the adjacent soft tissues. Okay, you can see here. Yes, this is ulcero-proliferative growth, and it is extending into the soft tissue. This will be much more apparent when you see the original gross specimen. I hope you have seen this in the practical hall. Yes, all of you have seen this?
Yes, sir.
Yes, sir.
Very good. So can you again discuss this? Any one of you?
So this is the specimen of squamous cell carcinoma, and the specimen shows mandible and part of cheek muscles, and
Okay.
there is also a proliferative growth in the mucosa which extends towards bone region or mandible also.
Okay, very good. Very good. If you can say this much, then you can slightly elaborate. Okay, you have to always say a cut section of the growth shows gray white areas, because the cut section is also shown here. This is the cut section. Yes.
Yes, sir.
Okay. Okay, good. That means we can move to the next. Okay, here it can these are the questions. You go through the questions yourselves. Okay, you can revise your practical logbooks also. 60-year-old female came with a history of non-healing ulcer in the oral cavity. Age is 60 years. Okay, and history of non-healing ulcer. The ulcer is non-healing for a long time. Then the specimen is given. Identify the specimen and write a diagnosis. This is squamous cell carcinoma of the oral cavity. Mention 5 sites where you may find the similar lesion. Means 5 sites where you might see the squamous cell carcinoma. So you can see squamous cell carcinoma in the lung, in the skin, in the cervix, in the larynx, in the esophagus, anal canal, and penis. So you should write these areas. So far, so good?
Yes, sir.
Yes, sir.
Okay. Till now, we have discussed about acute appendicitis, tubercular lymph node, which is the chronic inflammation, the lipoma, and carcinoma of the oral cavity. So we have already discussed about the carcinoma of the oral cavity. Can someone please tell about this gross specimen?
Gangrene.
Squamous cell carcinoma of foot.
Very good.
Carcinoma of foot.
Very good, very good. This is not gangrene. Someone was telling this is a gangrene, but here is a ulceroproliferative growth, more of a proliferative growth, irregular proliferative growth in the foot. So this is not a gangrene. This is a tumor which is malignant. Okay, this is squamous cell carcinoma of the foot. So the identification points. There is a specimen of the lateral aspect of the foot with part of the leg. This is the foot, and above the ankle it is part of the leg. This is part of the leg. So there is a irregular fungating cauliflower-like growth, exophytic growth arising from the skin, which extends into the underlying soft tissue. And there will be focal areas of necrosis and hemorrhage seen within the tumor growth. So these are the points which are in favor of squamous cell carcinoma of the foot. So you have to see the growth here. Is this clear?
Yes, sir.
Okay, can you revise?
So with the specimen is the lateral aspects of foot and the leg. The specimen show ulcerative proliferative fungating cauliflower-like growth, which is extending into the soft area and shows area of necrosis and hemorrhage.
Very good, very good. So a question can be this way. Ulceroproliferative growth in the leg of a 45-year-old man since 2 years. He says it is growing in the size and the ulcer did not heal with medicine. That means he is also having a non-healing ulcer for 2 years. And what is the diagnosis? And write 2 identification points to support your diagnosis. So you can write this. So gross number 6. Anyone, can you elaborate this gross?
Thrombosis.
Thrombosis.
Okay, Suryaraj, please carry on.
So it is a specimen showing thrombus clot blood.
Okay, it is a specimen of a thrombus. So, okay. Furthermore, so it is a specimen
In lines
showing
of Z.
Lines of Zan is a microscopic feature and not, you cannot see that in gross feature.
Lines.
Okay. Lines of Zan you see in microscopy, which we will be discussing in during microscopy sections. Here the specimen is shows a S-shaped cast of the blood vessel. That means it is a thrombus, and the external surface is granular and brownish. So you have to know what are the complications of a thrombus and what are the fates of thrombus. So can you tell two complications of thrombus?
Embolism, proliferation,
Infarction.
Okay, very good, very good. And what are the fates? Can you tell the fates of thrombus?
Propagation.
dissolution,
Resolution.
Okay,
Organization.
okay, that means you know. Okay. So a question will be, a patient reported to the surgical OPD with a sudden severe pain in the lower calf muscle. On examination, pulse in the dorsalis pedis artery was found to be absent. And this is due to the thrombus. The blood is not reaching to the dorsalis pedis artery and there is no pulse. So identify the specimen and what is line of Zan. So you have to write the identification is the thrombus, and line of Zan, you have to write what is the line of Zan. It is a aggregation of pain platelets and fibrin deposits alternating with the darker red cell rich layers. So that is known as line of Zan, which is found in antemortem clot or thrombus. So gross number 7. What is this? Can someone describe this?
Splenic infarct.
Splenic infarct.
Okay, very good. But why do you say this is a splenic infarct?
Pale color area of
Okay.
Infarct.
Okay, pale color area of infarct is seen. Otherwise, the parenchyma of the spleen will be dark. So it is a specimen of a spleen. There will be a well-demarcated gray-black areas, one of which appears wedge-shaped. Okay, an rim of pale area is seen between the dark areas and the normal viable tissue. Is this all right? So this is a specimen of a spleen where you can see the areas. One here you can see a wedge-shaped infarct is there. Here the wedge-shaped infarct is there. A rim of pale area is seen between the dark areas and the normal viable tissue. So discussion questions can be, what is an infarct? What are the different morphological types of infarct? So you have to give the types of infarct and mention 2 sites where a red infarct could occur. I hope you know this. Yes?
Yes, sir.
Okay. The red infarct and white infarcts, and what are the areas where you can see the red infarct? What are the areas where you can see the white infarct? What is an infarct? You all have to know this. And here there is a infarct. Infarct means whenever there is an infarct, the tissue will go to a state of necrosis. So which type of necrosis might be this?
coagulated.
Very good, very good. We'll go to the next topic after this. Identify the specimen spleen with infarct. Identification points which we have already talked about, and what are the types of infarct, red infarcts and white infarcts. Gross number 8. Can someone describe this gross specimen?
CVC of liver.
CVC of liver.
Okay, very good.
Chronic venous congestion of liver.
Very good, very good. During the exams, please do not use the short forms. Do not use the abbreviations. Always, if it is a, if even if the CVC is a well known term, please use chronic venous congestion and not CVC. Okay.
Okay, sir.
Okay. Always write the full form: chronic venous congestion, comma, liver. So, what are the features in favor of chronic venous congestion of the liver?
The specimen must be a
Structure.
This will be
Sorry.
congested blood vessels.
Okay, Surya, can you please go on, carry on?
So the specimen is of the liver.
Okay, very good.
Person shows congested blood vessels
Okay,
with nutmeg appearance.
okay, very good. So, what do you mean by nutmeg appearance?
So it is alternative dark and pale areas.
So, okay, alternative dark and paler areas will be there, which will have a appearance of a nutmeg. So that way it is known as nutmeg area. Okay. So you have to know that this is a liver with chronic venous congestion. In photograph, we are not seeing the nutmeg appearance that well because it is clicked. If you go to the specimen, here you can see the dark areas and white areas, again the dark areas, and somewhere in between there are pale areas, lighter areas. So this is a chronic venous congestion, and as a whole the liver will be enlarged itself due to the chronic venous congestion. So it is a specimen of the liver. Cut section shows congested areas. So as a whole there is congestion, and alternate black and pale areas are the normal looking areas or the fatty areas, and the black areas are the congested areas. The more the congestion, the darker will be the tissue. So alternate black and pale areas will be seen, which is known as the nutmeg liver. So the question will be: patient had right-sided cardiac failure. Patient had right-sided cardiac failure, so there will be congestion towards the. I have written congestion, chronic venous congestion of the spleen, but actually it is of the liver. And nutmeg liver, now you know that alternating area of darker areas and pale zones. Okay, that is nutmeg liver, resembling a nutmeg. Gross number 9. Someone please describe this.
Bronchiectasis.
Do you think it is a bronchiectasis?
TB lung.
TB lungs.
Okay, very good. Very good. Why do you say it is a TB lung?
Cavity in
Cavitation.
Very good. There is a cavity. There is a cavitation, and cavitation is mostly a feature of a tuberculosis in our area. There is a cavitation. There is a cavitatory lesion. This is a lung with this. This is the part of the lung, or one lobe of the lung with one part of the lung with hilum. Here you can see the bronchus, and here there you can see a cavitatory lesion. Let's see the identification points. This is the specimen of lung. Multiple irregular cavities are seen in the parenchyma, and cavitating lesions are lined by grayish yellow KGS material. Is this all right? So main thing here is the parenchyma with multiple irregular cavities. Okay. Here also you can see one cavity. Here also you can see a cavity. Otherwise, smaller cavitations are also there. And here you can see some areas of KGS necrosis. It is not prominent in this photograph, but there are areas of caseous necrosis. I don't know whether this is also area of caseous necrosis. So this is a specimen of a lung with multiple irregular cavities are seen in the parenchyma. So whenever this specimen comes, you have to write about the cavitatory lesions, or the cavitating lesions, and the caseous material. So whenever a tuberculosis comes, you have to write about the caseous necrosis, either it is a lymph node or a lung. You have to write about the caseous material, and particularly in the lung, you have to write about the multiple irregular cavities. So now you have to know about the gone focus, gone complex, and miliary and fibrocaseous tuberculosis. So a question will be 30-year male with history of weight loss, respiratory distress, hemoptysis, and low-grade fever, and along with the specimen. And what is the specimen? Pulmonary tuberculosis. And what is Ghon's complex? Now you have to know what is Ghon's complex. So what is Ghon's complex?
Caseating granuloma, connecting lymphatics, and
Okay. The lesion in the lung, okay, which is the tubercular foci in the lung, along with the node, hilar lymph node, that is known as Ghon's complex. So this is the 10th gross specimen.
Bronchiectasis.
Very good. Now this is bronchiectasis. Why bronchiectasis?
Enlarged
Dilated
airways
airways.
extending up to the pleura.
Very good. It is a specimen of a lung showing multiple cystically dilated airways, which is seen in the cut section, and extension of the dilated airways up to the pleura, or up to the subpleural lesion. Excuse me. So this leads to the gross diagnosis of bronchiectasis of the lung. So most important thing is multiple cystically dilated airways. Now you should not confuse these ear spaces with the small cavitations in the tuberculosis. Now you have to know the morphological types of bronchiectasis, and you have to know the causes of bronchiectasis. And question might be, a 40 years old female had productive cough. Okay. Now if you are confused with the specimen of a tuberculosis and bronchiectasis, sometimes this clinical history also might be of great help. And on occasion she noticed spots of blood in the sputums along with wheezing episodes. Lab investigations show increased WBC count with neutrophilia. Then what is your diagnosis and what are the possible etiological factors? So these are the possible etiological factors which you already know, and if you do not know, you have to go and revise this again. And the diagnosis is bronchiectasis. Shall we go to the next gross?
Yes, sir.
Okay. Can anyone describe this?
Bronchogenic carcinoma.
Okay. Can you tell why you told this is a bronchogenic carcinoma? Here are two figures, two gross pictures. One is this and one is this. Both are of same diagnosis. So particularly for this picture, why do you call it a bronchogenic carcinoma?
a gray white tumor mass.
Carry on.
Extended up to long parenchyma.
Okay, there is a long parenchyma with bronchus is here. You see this? This is a cut section of a bronchus. And in close proximity of this bronchus, there is a irregular gray-brown irregular mass. Okay, here the same thing. There is a mass. This is a normal long parenchyma. This is a long parenchyma with smaller bronchi. Okay, these are the larger ones. And you can see irregular mass. So this is a specimen of portion of the lung. A tumor composed of gray-white area is seen, and the tumor is seen extending into the surrounding lung parenchyma. So this is what you have to write exactly. And these are the questions. For example, a 60 years old male with history of chronic smoking since last 20 years presented with breathlessness, hemoptysis, chest pain, weight loss, and anorexia. Breathlessness because the lung is involved, hemoptysis, okay, chest pain, weight loss will be there, anorexia. If all these features come, then it is a malignant tumor. Then what are the two causes of this tumor, and name the two paraneoplastic syndromes associated with this tumor. So you have to know this, like cigarette smoking or asbestosis might cause this tumor, and paraneoplastic syndromes can be SIADS or Cushing syndromes producing the, or ACTS producing the producing Cushing syndrome can be there. Is it okay?
Yes, sir.
Okay, you have to identify this is a long parenchyma, and along with long parenchyma there is a irregular gray-white mass, which is present in the lung. Okay, and this will be towards the bronchus. So this is known as bronchogenic carcinoma. Let's go to the another one. So this is the gross number 12. Can anyone describe this gross specimen?
Atheromatous plaques.
Okay, this is atheroma or atheromatous plaque of the aorta. So this aorta has been cut and it has been kept there as a flap. Okay, it should be a tubular structure, but it has been cut from one side and it has been laid here as a flap. And here are multiple atheromatous plaques. Here also you can see atheromatous plaque. The identification points will be specimen of aorta. The luminal surface shows multiple yellowish white patches and plaques, and majority of the plaques are oriented around the ostia of the major blood vessels, and few of the large plaques show chalky white areas of calcification. Okay, here also you can see chalky white areas of calcification, and here you can see the ostia of the blood vessels, and they are mostly around these ostia. Ostia means from where the other smaller calibered blood vessels arise. The opening of those areas are known as ostia. So in questions, what are the risk factors for atherosclerosis, and what are the stages of formation of an atheromatous plaque, and what are the complications of an atheroma? These are the questions. With these identification points, you can write for example, a question might come: on postmortem of a 50-year-old obese man, a lesion was found on the aorta. Identify the lesion and name two complications of the lesion. Like Identify the reason: atheromatous plaque of the aorta, and complications can be myocardial infarction, stroke, aortic aneurysm, or gangrene of the leg. Why does gangrene of the leg occur in atheromatous plaque of the aorta?
Aortic side of heart.
Can you be more precise?
So due to blockage of blood supply.
So there is a blockage of blood supply in the aorta. So
Embolism.
very good, very good, very good. It should be embolism, because atheromatous embolism will be there. Otherwise, why should there be a gangrene of just the isolated leg? All right, so this should be a embolism. Let's go to the next gross specimen, 13th. Can you identify this gross specimen?
Carcinoma of colon.
Carcinoma of colon.
Okay, carcinoma of colon. Very good. In carcinoma of colon, we have carcinoma of colon of two sides. One is the proximal side and the one is the distal side. Okay, why? Because morphologically they two have distinct appearances. What we see, this is a proximal carcinoma of the colon. You see, this is a specimen of a part of a colon, and cut section shows large ulceroproliferative exophytic growth on the mucosal surface projecting into the lumen. The growth has heaped up margins and ulcerated central portion with necrotic areas, and the growth is seen extending up to the serosa. So here you can see a large ulceroproliferative exophytic growth on the mucosal surface projecting into the lumen. So this is the mucosal area, and behind this it is the serosal area. So here you can see a irregular ulceroproliferative growth with heaped up margin. Means here you can see depressed area, which is the necrotic area, but towards the margin it has a heaped up, okay, or thickened area, heaped up margin, and this looks very friable and irregular mass is there. So this is a carcinoma of the colon. A question might come: a 17 to 74 years old man came with rectal bleeding. Specimen of colon is shown. Write your diagnosis with two identification points, which you can write now, and list two gross morphological types, which are proximal and distal. Like proximal, if it is a proximal area towards the ascending colon or the part of the transverse colon, then polypoidal, exophytic, claudiflower-like growth. Whereas distal type, there will be more of a constricting annular lesions producing napkin ring-like constrictions. Okay. Now let's go to the 14th gross. Can anyone describe this specimen?
Carcinoma of colon distal.
Very good. Why do you call it a colon carcinoma of the distal part?
So we see constricture due to napkin ring formation.
Very good, very good, very good. We see a constricting type of growth, creating a napkin ring-like constriction. Here it is a specimen of part of the colon where we see cut section showing a circumferential growth constricting the lumen of the gut, and the part of the colon distal to the growth is normal, while proximal part is distal to the this is the distal part and this is the proximal part. Okay, here this is the proximal part. Here all the fecal materials are getting collected, but it is not going beyond this, so this will get dilated, whereas this will be normal. Is this clear?
Yes, sir.
Okay, then obviously the mucosa of the proximal dilated part appears to be thinned out. So question might be same as that of the proximal part. 72-year-old male presented with large bowel obstruction. Here the main thing will be the bowel obstruction, as it will have a napkin ring like constrictions. Okay, so if any patient has a carcinoma colon, it is better to have a distal type, so that they will have early large bowel obstruction leading to constipation, and then he will be seeking the he will go to a doctor to check up early. So what is the diagnosis? Write 2 causes of this condition. You have to write, and what is napkin ring growth? This also you have to write. I hope you can write this. So we are almost at the end of time for today. We still have some. We have finished only the 14 gross specimens, and we have to reach up to 23. So we'll continue in the next class. I hope everything is clear today.
Yes, sir.
Okay. Any problem with any of the specimens?
No, sir.
Okay. Then we have to revise from your practical logbooks. And next time we'll be going through the gross specimen remaining, and then we'll start the microscopic slides. So be prepared with the gross specimens if you have any questions, and then if you have any queries, you be prepared with that, and the slides, microscopic slides also. You have to see once and then come to the class. Okay. So we'll pause it here for today, and then we'll continue next class.